like to thank the organizers for inviting me to present this talk and thank all of you for attending. I'm going to be talking about cardiac implantable electronic devices, which is a general term that involves any device we implant in the body to monitor and or treat the electricity of the heart. This includes pacemakers, defibrillators, in addition to implantable loop recorders. I'm sure a lot of you in your practice are seeing more and more patients with these devices, and I can appreciate that since you're not seeing these on a day-to-day basis, not interacting with them, there may be some questions, concerns about how these devices work, how they may interact with any procedures you may want to do for your patient, and if there is any potential device malfunction. So hopefully by familiarizing or refamiliarizing you with some of these core concepts, you'll be more comfortable approaching these patients. I will start off by going over some definitions. I'll highlight some of the major indications and contraindications. Briefly, I want to discuss how these devices are programmed, both pacemakers and defibrillators. And then finally, I'd like to go through some common clinical scenarios, which I'm sure most of you have encountered in your experience. The basic components of a CIED are quite simple. You have the generator, which houses the battery, the circuits, everything the device needs to do. And this is connected to the heart via leads. Traditionally, these are transvenous leads, which are inserted transvenously and inserted endocardially. But now we're also starting to see subcutaneous leads, as is the case with subcutaneous defibrillators, as well as completely leadless devices such as the leadless pacemaker, in which everything is housed in a small capsule that is inserted into the right ventricular apex. The best way to approach these devices is to simplify and classify them in what they do. You have those devices that simply monitor, which are your loop recorders, and those that can monitor as well as administer therapy. Those are either pacemakers or defibrillators. Pacemakers are best thought of as Brady devices. These are devices we implant to treat bradyarrhythmias. These are easily identified on a chest X-ray by the appearance of a smaller pulse generator as well as leads. And you can sometimes differentiate these on an X-ray based on the pulse generator size, but the best way is to look at the right ventricular lead and identify the presence or absence of high voltage coils, which are radio-opaque coils that I'll show in the next slide. A leadless pacemaker, however, will look completely different on an X-ray, and you could easily miss it unless you're looking for it, since it's a tiny, small capsule, and it's usually visualized within the cardiac shadow. An ICD is better thought of as a tachy device. These are devices we implant in patients to protect from life-threatening arrhythmias, namely VT or ventricular fibrillation. On an X-ray, as I said, the pulse generator will be a little bigger, but again, the defibrillator lead will have the high voltage coils, which you can see there are two of in this, and these are vectors that the device will use to defibrillate the heart. And then in comparison, a subcutaneous defibrillator, while also having a lead and a generator, will be in a very different appearance, likely in a different location. The generator is more lateral and outside the thoracic shadow, and the lead will traverse over the sternum. And then obviously we need to discuss CRT, or cardiac resynchronization therapy. This has gained a lot of traction and it's been for a while now, but it's still the mainstay of managing patients who have distal conduction disease. It is an attempt at trying to synchronize or simulate native conduction in the ventricles. As you know, your His-Purkinje system is a high-speed network and allows your ventricles to depolarize in a very nice simultaneous fashion. When we implant pacemakers, we usually can't do that or simulate that since we're pacing the endocardium and it's relying on cell-to-cell conduction. However, by putting a left ventricular lead, and I use this in quotation marks because the way we reach the left ventricle is via the coronary sinus and ventricular branches. And pacing a more lateral posterior aspect of the left ventricle, in addition to the right ventricle, will allow for a more homogeneous ventricular depolarization. These leads can also be implanted surgically if you can't access them transvenously. And then, as I said, these are implanted to try to synchronize ventricular depolarization. They will lead to a dramatic change on surface ECG, namely in V1, where you will see the presence of an R wave, which indicates posterior ventricular depolarization, as opposed to traditional right ventricular pacing, where you will see a QS pattern in V1, kind of like a left bundle. And finally, implantable loop recorders, as I mentioned, are purely monitor devices. They are not capable of administering any therapy. They are small, extravascular, inserted subcutaneously, and will record any significant brady or tachycardic events, as well as patient-activated events. And these can last up to 2 to 3 years and are very helpful for patients who have very infrequent symptomatic episodes that you are concerned could be arrhythmic in etiology. Indications. Not to bore you, I'd like to just jump into the main indications. I would highly recommend reviewing the guidelines because there's plenty of indications, they're very well written. But by far and most, the 2 most common indications or reasons that we implant pacemakers are symptomatic bradycardia or pauses and the presence of high-grade or distal atrioventricular block, which is characterized on surface ECG as Mobitz 2 high-grade or complete heart block. It's very important to make sure that these are not due to reversible etiologies before committing your patient to a permanent device. Reversible etiologies that we should look for, or common culprits, include hyperkalemia, acidosis, hypoxemia, excuse me. Medications. Obviously, you'd want to stop any dromotropic medications such as beta blockers or calcium channel blockers. Traditionally, we used to stop beta blockers, wait a couple of days, but from experience, we've come to notice that patients on regular therapeutic doses of beta blockers or calcium channel blockers are probably at risk of developing further events even if you stop that. So it's usually only cases where combinations of these drugs or super therapeutic doses are used that we can really say this is a reversible etiology, if that makes sense. And then I also want to touch on vagal tone. Vagal tone is a very important cause of bradyarrhythmias, reversible bradyarrhythmias. As you know, the conduction system of the heart is under the control of the vagus nerve. So if you have a very high vagal tone, it can lead to bradyarrhythmias, and a lot of times this is paroxysmal and reversible, as is the case in sleep apnea or reflex syncope or vasovagal syncope. For instance, a lot of patients you'll see come back with Holters, you'll see pauses at night or Wenke block, if not higher grade AV block. But if you can correlate these with sleep and the patient is asymptomatic, it is probably indicative of underlying sleep apnea. When it comes to ICD indications, as I said, these are tachy devices. We implant these to protect the patients from life-threatening arrhythmias. Those who have already suffered such an arrhythmia and recovered with no reversible etiology identified qualify for these devices on a secondary prevention basis. But we also implant these as a primary prevention device in patients who we know are at increased risk based on numerous studies, but usually patients with a reduced ejection fraction who have been optimized on medications and revascularized with no significant improvement in EF beyond 35%. Again, it is very important to make sure there is no reversible etiology. Traditionally, we consider the 48-hour window after a major ACS or ST elevation MI a reversible ventricular arrhythmia. However, it is important to distinguish polymorphic ventricular tachycardia from monomorphic ventricular tachycardia. Ischemic ventricular tachycardia is usually polymorphic VT or VFib. The presence of sustained monomorphic VT usually indicates the presence of scar. So even in the acute setting of an MI, if you see sustained monomorphic VT, that should raise your suspicion that this patient is at risk of further events, and you may need to consider an ICD in such a patient. Another important distinction to make is VT in a structurally normal heart from a patient with VT in a structurally abnormal heart. VT in structurally normal hearts, we know, are better prognostically, and these patients aren't at risk at sudden cardiac death. And the reason is the mechanism of this VT, as opposed to scar-mediated reentry, is due to automaticity. And these patients usually are treatable or can be treated by ablation or medications and aren't technically ICD-treated ventricular arrhythmias. And then finally, since these devices offer purely a mortality benefit and not a morbidity benefit, it is important to assess your patient prior to implantation and whether they will benefit from this. Bedridden or patients with metastatic cancer probably don't qualify for these devices since they will likely die from other etiologies in the near future. And then briefly, CRT. As mentioned, with CRT, we are trying to replicate the electrical depolarization of the native heart. And we try to do this by inserting 2 leads, one in the right ventricle and one close to the left ventricle. And patients who will benefit from this are those who demonstrate the evidence of intraventricular conduction delay. Those that respond best are those with a left bundle branch block and a really wide QRS. but even those with a non-left bundle branch block morphology may benefit from such procedures. And also, patients who are dependent on pacing and have a reduced EF will also benefit from a CRT as opposed to pure right ventricular pacing. When it comes to pacing modes, I'm sure you've seen the terms VVI, DDD, AOO, and all these basically represent are what chamber is paced, what chamber is sensed, and the response to a sensed event. That's the best way to approach those three letters. The fourth letter may or may not be present, and that just indicates the presence of rate response. Rate response is a feature in the device that tries to predict if the patient is exerting themselves or moving and trying to increase the heart rate to accommodate for that. But when it comes to the first three letters, VVI, for instance, chamber pace is the ventricle, chamber sensed is the ventricle, and the response to ventricular sensing is inhibition. So VVI pacing is pure backup pacing in the ventricle. And this is demonstrated in this ECG here. Here you can see a patient who has relatively slower or well-controlled atrial fibrillation. And if you pay attention to V3, you can see the second beat, the QRS is a little wider. It's preceded by a small pacing spike, and it occurs after a relatively longer period. If you think about it, the right ventricle is the right ventricular lead is observing the right ventricle. And once the rate drops below a preset cutoff, it will administer pacing. Anything above that will inhibit pacing, and that is pure backup VVI pacing. As opposed to DDD pacing, where we have AV synchrony in that each P wave is associated with a QRS complex as long as it is not above a certain rate. Here you can see the patient is in sinus rhythm with clear P waves followed by paced QRS complexes. This patient has atrial sensing, ventricular pacing, and this is DDD pacing. A common misunderstanding is a patient goes for a pacemaker, comes back, and is in pacing. And then the question is, well, why isn't the pacemaker working? Now, it's true. Most patients get pacemakers for bradyarrhythmias and will need pacing. However, sometimes these bradyarrhythmias are paroxysmal. In such a situation, the pacemaker will only work when needed. This is for multiple reasons. As I mentioned before, pacing the right ventricle, or I actually didn't mention this, but chronic right ventricular pacing can lead to a drop in ejection fraction. Also, you want to prolong the battery life as much as possible. So the only times you should suspect a pacemaker malfunction is if you see significant bradycardia without pacing. And usually less than 40 beats per minute should raise your suspicion, why isn't the pacemaker working or kicking in? Also, if you see pacing spikes that are not followed by a deflection, such as a P wave or QRS, that should also raise your suspicion that there may be a problem with the pacemaker or failure to capture. Here I have an example of a patient who has a dual chamber pacemaker, and right off the bat, you can see something's off. You can see in the lower rhythm strip periods of no QRS complexes. If you pay closer attention, you'll see this patient is in sinus tachycardia. Each P wave is followed by a pacing spike. However, not all these pacing spikes are followed by a QRS complex. And this is failure to capture. The pacemaker is pacing, but the lead is not capturing. And in this patient, the lead had been pulled quite a bit, and it was on the verge of dislodging, and this patient needed a lead revision. So this is a classic example of, okay, this patient has a pacemaker malfunction, we should alert the electrophysiologist. When it comes to ICD programming, however, it's the opposite. Here, we're trying to protect the patient from ventricular arrhythmias. So we set a cutoff. We tell the device, anything above this rate, consider VT and treat the patient, be it anti-tachycardia pacing or shock. It will not deliver any therapies below that preset zone. You can set multiple zones with different therapies. However, as you know, not all tachycardias are ventricular. Supraventricular tachycardias can also approach those rates. And while most of these devices do have algorithms to try to distinguish SVT from VT, and the presence of atrial leads can also assist, at the end of the day, it is the rate that is going to determine whether the device will shock the patient or not, and nothing is really 100% accurate. And that brings us to the concept or the theory of the problem of inappropriate shocks. This is one of the reasons we try not to put ICDs in everybody, or one of the concerns of putting an ICD in a patient. The last thing you want is to put an ICD to protect somebody for them to come back getting shocked by it for no reason. It is very painful and very traumatic. Inappropriate shock is defined as a shock delivered in the absence of VT, because like I said, these devices are implanted to save lives and treat VT or VFib. This could be due to, as mentioned previously, SVTs triggering these therapies, in which case treating the underlying SVT or maybe reprogram the ICD is all that is necessary. However, sometimes problems with the lead, fractures, dislodgement, can lead to non-physiologic noise that will trigger ICD therapies, and in this case, the need will need to be revised or completely changed. And now I'm just going to go over a few cases just to hit on some few concepts. This just what we're talking about. Patient comes to you with ICD shocks. So looking at his ECG, you can tell he's not in a YQRS tachycardia. It's narrow, it's irregular, there's no P waves. You would not be faulted for immediately saying this is atrial fibrillation with a rapid ventricular rate. When approaching a patient who says he's had ICD shocks, the first question is, did he truly receive an ICD shock? It is important to make sure the patient has a device capable of delivering shocks. And the reason I say this is because during my training, I got called in for a patient who got shocked only to find out he had a loop recorder. So just make sure the device can actually deliver shocks before you open this whole thing. But once you're sure he has an ICD and he's been shocked, the next question you ask yourself is, was this shock appropriate? If you're lucky and the patient is very unlucky, they are being shocked right in front of you. In that situation, looking at the telemetry or getting a quick ECG will allow you to look at the rhythm, analyze, and decide, should he be shocked for this rhythm? However, a lot of times the patient will come to you, he says, I got a couple of shocks, but by the time he gets to you, he's in sinus rhythm. In that situation, the only way to determine whether the shock was appropriate or not is to get a programmer, interrogate the device, and review the electrograms. It's appropriate if it was for VT or VFib. But like I said, any other rhythm is considered an inappropriate shock. And the way to manage this is to reprogram the device, plus or minus revise the lead. However, in certain situations, the patient's getting shocked right in front of you, you need to do something fast. In that situation, that's where a magnet will come in handy. The magnet response is an excellent feature programmed in all pacemakers and defibrillators, which allows the quick ability to alter one thing about these devices purely by the presence of a magnet over the generator. The device will sense this and alter one of its functions. This effect differs in a pacemaker and a defibrillator. In defibrillators, putting on a magnet will immediately turn off any tachycardia therapies. As long as the magnet is on the defibrillator and is sensed by the device, no shocks will be delivered. So in the previous situation where a patient's getting shocked by his ICD and continues to get shocked while being in sinus rhythm, putting on the magnet will inhibit these therapies and you can proceed with managing this patient while avoiding further shocks. In pacemakers, however, putting on that magnet will switch them from whatever programming they are to asynchronous pacing. And if you remember chamber paced, chamber sensed effect, it will basically pace a chamber without looking, without doing anything. It's just pacing, pacing, pacing at a fixed rate. This is very safe in patients who have no underlying rhythm and are dependent. However, in patients who have an underlying rhythm, asynchronous pacing theoretically can be dangerous. So it is important to make sure of that before putting on a magnet in a patient with a pacemaker. In patients who have ICDs and are dependent on pacing, putting on a magnet will not change the pacing therapy, and that's important to keep in mind if this patient is at risk of electromagnetic interference, because those will need reprogramming. And sorry, one last thing. Once you put a magnet on, that effect will stay as long as the magnet is on, but once you take it off, all prior settings will restore. You don't need to interrogate the device. However, it is encouraged for the device to be interrogated within a few weeks. Another common scenario is a patient who just got a device or got a device a couple of years ago and reports swelling or discharge from the generator site. One of our biggest concerns is device infection, and the reason is if any part of the CIED is infected, it can track all the way into the heart, lead to vegetations, endocarditis, and in that situation, everything needs to come out. Sometimes you will have a patient who has a superficial or incisional site infection. However, you need to be very careful that this is not tracking all the way down. You can manage those patients with oral and topical antibiotics as long as they are not systemically septic, but you need to be careful because sometimes that is a sign of a more sinister infection. And obviously, I'm sure you've heard this before, never try to aspirate anything at the bedside because you could be introducing something. And then the last scenario is probably the most common scenario you will face, is a patient who has a CIED and needs to undergo an MRI. MRIs generate magnetic fields and RF energy. These electrical signals can be picked up by the pacemaker or defibrillator. And since these devices work based on signals, this may alter their function, and this is what is called electromagnetic interference. Years ago, pacemakers and ICDs were considered a contraindication. You can't get an MRI if you have a pacemaker and ICD. We still sometimes do them, but there was a risk. But now, luckily, most contemporary devices carry an MRI conditional tag in that you can undergo an MRI up to 1.5 Tesla as long as certain conditions are met, as long as the patient doesn't have any abandoned leads, and it will require pre-programming and post-MRI programming. But back to electromagnetic interference. This is the concern with MRIs as well as monopolar electrosurgery. The concern is, since these devices rely on electrical activity to function, if they pick up electricity from somewhere else, it won't know. All it knows is it's seeing electricity. So electromagnetic interference in a pacemaker could inhibit pacing, and in a defibrillator could trigger inappropriate therapies. And this risk depends on many factors. It will depend on patient factors, such as why does the patient have a device? What's his intrinsic rhythm or rate? It will also depend on the device itself. What's the pacing mode? And most importantly, it depends on the source of electromagnetic interference. What is the location? What is the strength? What is the duration? The reason I bring up all these factors is just to highlight how it is not as simple as turning off a switch. Any patient who has a device undergoing a procedure or MRI needs to be properly assessed to determine what the best route is based on whether or not EMI is a risk. Here is an example of a patient who has a pacemaker and is undergoing monopolar electrosurgery. At the top, you can see electrograms recorded from the pacemaker, and at the bottom, the arterial waveform. You can see a lot of noise and artifact in the EGMs at the top. And at the bottom, you can see towards the end a period of asystole. And the reason is the device is seeing these signals. As long as it's seeing its signals, it'll get inhibited. And this can potentially lead to clinically significant asystole. However, if the anesthesiologist is paying attention or the surgeon's paying attention, as soon as you come off cautery, everything will go back to normal. But this is just to highlight how electromagnetic interference can interfere with a pacemaker's function. And here is an example of electromagnetic interference doing the opposite and triggering an ICD shock. Same situation. A lot of noise will be picked up by the lead. It can't tell if this is artifact or not, so it'll do what it's programmed to do, which is shock. Monopolar electrosurgery is the most common type of electrosurgery or cautery that is used. Bipolar surgery, which is only used in ophthalmologic or certain vascular surgeries, is not usually a source of EMI, but when you're using monopolar surgery, there's a return patch, electricity will course through the body, and it's considered a source of electromagnetic interference. It's unlikely, however, if it's below the umbilicus, so lower extremity surgeries are usually not a concern. But in a patient with EMI and anticipated risk of clinical decompensation, the approach will depend on whether this is an emergency or elective procedure. If it's an emergency, you can put on a magnet or try to limit the cautery to short bursts. However, if it's elective, you have time to assess the patient and reprogram the device based on the patient's needs.
Ali, you have 2 minutes. Huh?
Yeah, I'm done. Thank you.